Welcome to this presentation on occupational therapy. My name is Allie Lindsay, and I am a capstone student in OT. My capstone was focused on promoting the utilization of OT for delirium management in critical care. This presentation was created to provide the interdisciplinary team with an understanding of what OT is, our role in acute care, and our role in delirium management. So first, to understand occupational therapy, we need to understand what occupations are. My personal elevator speech is that occupations are the things that occupy your time, the things that you need and want to do every day. The OT practice framework states that occupations are everyday personalized activities that people do as individuals, in families, and with communities to occupy time and bring meaning and purpose to life. All of the things that we participate in can be categorized into one of these 9 categories. The first is activities of daily living, or ADLs. The next is instrumental activities of daily living, or IADLs, which are activities that support daily life in the home or in the community. And these things can include childcare, pet care, driving, money management, meal prep, shopping, and more. The next is health management, which relates to developing, maintaining, and/or managing health and wellness routines through medication management, nutrition, physical activity, and more. The next occupation is rest and sleep. And rest and sleep is typically thought of to be obtained for healthy engagement in other occupations. Education is the next occupation, and this includes both formal and informal educational activities. Work looks at participation in job duties, as well as seeking employment, retirement, and volunteering. The next occupation is play, which adults typically do not engage in often. Next, we have leisure, which is intrinsically motivating activities that do not relate to occupations such as work or ADLs. And last, we have social participation, and these are activities that involve interactions with others. Now that we know what occupations are, what is occupational therapy as a profession? Again, my elevator pitch is that when there is a disruption in an individual's participation or performance in their occupations, for whatever reason, we as occupational therapists are used to support and promote engagement in meaningful occupations. We therapeutically engage with clients in daily life occupations to promote participation. Our interventions are client-centered and occupation-based, meaning they are based in the knowledge of the person, participation in meaningful occupations, and the context. The OT practice framework once again says that occupational therapy services promote acquisition and preservation of occupational identity for those who have or are at risk for developing an illness, injury, disease, disorder, condition, impairment, disability, activity limitation, or participation restriction. We also utilize something called activity analysis, which means that we break down each step of a task to optimize performance. For example, if our patient is struggling with balance, this will affect their participation in so many occupations. We need to address this before we can address the higher level occupations such as ADLs. So what do we have to do to become an OT? So occupational therapy is a graduate level degree, and it has 2 options currently, either an entry-level master's degree or an entry-level doctorate degree. Doctorate programs are about a year longer, and this year includes a doctoral capstone, which is what I'm currently on. And this capstone focuses on translating the evidence found in a literature search into clinical practice. All OT coursework typically includes aspects of anatomy, biomechanics, therapeutic use of self, pediatrics, older adults, physical dysfunction, mental health, and evidence-based practice, and so much more. We participate in clinical experiences called fieldwork. Level 1 fieldworks are only 40 hours long, and we begin to implement some assessment and treatment into these fieldwork experiences. Whereas level 2 fieldwork experiences are about 12 weeks or so, and it's full time, where we begin to build a caseload. Once we graduate from OT school, we take a national board certification exam. Then we need to become licensed in the state where we are practicing. So what is OT's role in acute care? Occupations differ greatly when patients are in the hospital than when they are outside of the hospital. So we look at what habits the patient has and whether or not they are supporting participation in occupations. Additionally, we are examining their routines and roles while in the hospital and what those routines and roles will look like when they discharge from the hospital. We are also looking for changes in their functional abilities from when they came into the hospital to when we are evaluating them. Traditionally, we focus on self-care and ADLs, but we can also provide support for patients in the occupations of rest and sleep, as well as social participation, leisure, and work. Again, we are looking at their baseline functional abilities and working to help patients make it back to their baseline. Additionally, the framework states that occupation serves as the connection to returning home and to productive living post-discharge from hospitalization. We are analyzing what the patient is able to engage in successfully and safely. We are also determining what kind and how much assistance they require to engage in these occupations. And this is typically what we will make our recommendations off of. So we all know that patients in the hospital are all of these things here. So they are all not acting as they normally would. They are not following commands. They are tired and sleepy. They are sedated and or have a low RAS typically. They're confused, they're agitated, they're weak, and they're restrained. OTs can still provide skilled intervention to these patients to facilitate responses, which may include patients' increased alertness, awareness, and command following to increase participation in occupations. So you're probably thinking, what is the importance of these patients being seen by OT when they are these things? And I would say delirium and delirium prevention. So this is how delirium is described by the DSM-5 criteria. And that criteria is disturbance in attention and awareness, acute and fluctuating change in mental status from baseline, additional disturbance in cognition, such as memory. Disturbances are not explained by an established or pre-existing neurocognitive disorder, and that's including a coma. And the last criteria is the disturbance is a direct physiological consequence of a medical condition, toxin, or it can be a consequence of multiple etiologies. The CAM-ICU is the tool typically utilized in critical care to determine whether a patient is experiencing delirium. There are also 3 different types of delirium. The first is hypoactive, and this is characterized by diminished alertness, attention, responsiveness, and body movement. Hyperactive is characterized by agitation, hallucinations, inability to concentrate, irritability, preservation, and increased body movements. The last one is a mixed delirium, and that is fluctuating characteristics from both hypoactive delirium and hyperactive delirium. Delirium is a problem in the older adult population, but it also may be prevalent in younger individuals that are critically ill. The epidemiology for critical care is 47 to 87% of all individuals that are admitted to these critical care or intensive care units. In general medicine, in the other floors of the hospital, 11 to 25% of older adults have delirium upon admission, and then an additional 29 to 31% of older adults develop delirium during their hospital stay. These are some common risk factors for individuals that are diagnosed with delirium. So these are pre-existing dementia, low cognitive reserve, advanced age, high comorbidity burden, visual impairment, depression, alcohol abuse, malnutrition, and narcotic use and alcohol abuse. Here are some possible causes of delirium: high illness severity, infections, dehydration, electrolyte imbalances, kidney liver failure, withdrawals, seizures, nervous system dysfunction, cardiac dysfunction, pulmonary dysfunction, trauma, pain, medication, and an unfamiliar place. Usually there's many factors and causes behind someone developing delirium, not just one reason. It is a multifaceted condition, which makes it difficult to treat. So why should all of us care about delirium? Well, it is very common and has impacts at the hospital level and the patient level. Some hospital level impacts are the length of stay patients are in the hospital and their days on ventilation. Some patient level factors include increased mortality, decreased functional ability, and persisting cognitive impairment. We should really be concerned about the decreased functional ability and persisting cognitive impairment. This is also where we might be able to make the biggest impacts as occupational therapists. So, what is OT's role in delirium? My capstone project found that non-pharmacological interventions were effective at decreasing rates of delirium. These OT interventions included early mobility, sensory stimulation, positioning, cognitive retraining, upper extremity function, basic activities of daily living, and family education and involvement. The first intervention is early mobility. Sometimes this is what OTs and PTs are known for, especially in critical care. Immobility has effects on all organ systems, as you can see in this table to the left. Not to say that bed rest does not serve a purpose in acute care, because it does. It obviously does. However, inactivity and bed rest may cause deconditioning that decreases participation in ADLs and IADLs. Research has shown that early mobility improves patient length of stay, days on ventilation, and days experiencing delirium. Early mobility interventions with therapy may include positioning in chair position in the bed, exercises, dangling edge of bed, transfers to chair or commode, or functional mobility and ambulation. While early mobility is important and within the scope of OT, not all patients are appropriate for this level of activity, and OTs utilize clinical judgment to determine what other interventions may be beneficial. Or they can also determine if the patient would not benefit from intervention. So some of these interventions that do not include early mobility may include sensory, and that would be implementing polysensory techniques to facilitate responses from patients. And these techniques may include challenging all senses, including sight, smell, tactile, and auditory. The next is positioning. And positioning interventions facilitate proper positioning to protect skin from breakdown, promote postural alignment, and enhance function. Cognitive retraining interventions challenge the mental functions of patients through reorientation, sustained attention, social interaction, awareness, and sequencing simple tasks. Upper extremity function is addressed by educating patients on exercises, creating splints for optimal upper extremity positioning to preserve function. Basic activities of daily living are interventions that promote participation in simple tasks that are meaningful to the patient, providing the just right level of assistance. These tasks may include grooming, bathing, dressing, feeding. And lastly, family and caregiver involvement. This can include providing education to patients' families on delirium, the role of healthcare professionals, training on signs of delirium, safety, and promoting family engagement and care. In summary, here are some of the main points I hope you take away from this presentation. First, that occupations are any things that occupy your time. Next, occupational therapists in acute care work to help patients return to their functional baseline and assist in recommendations for their next level of care. Third, delirium is a common condition in the acute care setting. Occupational therapists have a role in managing delirium through non-pharmacological means, which include early mobility, sensory, positioning, cognition, upper extremity function, participation in basic ADLs, and family and caregiver involvement. While early mobility is very important, other interventions may provide benefit to patients also. And lastly, collaboration is so important. We should always be collaborating with each other and learning from each other. Thank you for listening to my presentation. I hope that you guys learned something about OT today and will work with us in the future to create the best outcomes for all of our patients.